Hi, my name is Peter Lewis. I'm the Director of Marketing at Experience Care. Today, I'm excited to interview our Financial Product Manager, Sue Friest. She's been in long-term care since the 1990s, and worked in client services, implementation, and now financial area. Insiders call her the PDPM connoisseur. Today, we'll call her Sue. Excited to have you back to explore today's interesting topic, Sue, PDPM and the interrupted stay. Let's start with something that might seem simple, but let's frame the conversation with what is the interrupted stay, Sue?
I don't know if anybody would call it interesting, but the interrupted stay, if a resident leaves the facility while they're in a PDPM coverage, an interrupted stay would mean that they left for less than 3 days. So it's kind of, it's not a new stay when they come back, it's an interrupted current PDPM stay.
Got you. And so I asked you ahead of time why this is important, and you replied, well, if the stay is interrupted, then the variable per diem and the assessment schedule are not affected. Can you break this down a little bit for us? Just imagine that I'm a nurse, day one of training. What does interrupted mean? What is the variable per diem? Why is it important? And why is affecting the assessment schedule matter? And then we'll dive in deep a little later.
Okay. It would be interrupted, like I said, if they left the facility and came back in within 3 days. And the reason why Medicare came up with the policy is that there's a variable per diem, and if it's an interrupted stay, then that variable per diem does not start its count over. And as far as the assessment schedule, it makes it a little easier on the nurses. They don't have to do a brand new admission assessment when the resident comes back in if it is an interrupted stay.
Got you. And I asked you to send over some documentation that our readers and watchers would have handy. And you tracked down some documents that I just want to share, and I'll let everyone know that these will be available inside of the blog or vlog. And some of the documents you send over that you use to prepare for this are interrupted stay fact sheet, the administrative level of care presumption, PDPM payments for SNF patients with HIV/AIDS, concurrent group therapy, interrupted stay policy, MDS changes. So we'll get to those in a little bit. But Sue, thank you for these documents and for organizing them. Now let's dive into the topic a little bit more. When is a stay interrupted? And feel free to go into the nitty gritty.
Okay. A stay is considered interrupted, like I said, if the resident leaves the facility for some reason. They may go home, they may go to the hospital, but if they leave the facility and return to that same SNF facility within 3 days, no later than the 3rd calendar day after they left, then that's considered an interrupted stay. Another possible reason for an interrupted stay, the resident remains in the facility, but they're moved to a lower level of care. But within those 3 calendar days, they need to go back to skilled Medicare coverage. So it would not be an interrupted stay if the resident leaves the facility and returns more than 3 days later to that same SNF. That is not considered an interrupted stay. Additionally, if the resident leaves a facility and is admitted to another SNF, even if it's the exact same day, that new stay at the new SNF is not considered an interrupted stay.
Is the 3-day arbitrary? Do you know where that comes from?
It comes from the fact, I've heard that it comes from the fact that if it's less than 3 days, there's not as much work that the facility has to do in order to bring the resident back into the facility. The acute care hospitals, rehab facilities, they all have this same sort of 3-day interrupted stay policy. So long-term care is now adapting to it because of the way that changes were made when PDPM came along.
Well, that leads me, I guess, to the next question. Why did Medicare create this policy for PDPM?
So previous to PDPM, we were paid on RUG scores, and it was just, you got paid the same every day for whatever RUGs that resident was at. With the PDPM came along, we now have a variable rate per day. So that's why the 3-day hospital stay, they had to determine some way, when would those days, that day count, start over.
And I know that you did an in-depth interview with our CEO, Jason Long, about the change from RUGs to PDPM, but could you refresh our memory, especially for those of us who might not have seen that interview? Why they moved from RUGs to PDPM?
Yeah, they moved from RUGs to PDPM, which PDPM stands for patient-driven payment model. So they wanted to focus more on the resident's total condition rather than RUGs really focused a lot on whether or not the residents were getting therapy and how much therapy they were receiving. PDPM now looks at more of the resident. It still looks at the therapy piece, but it looks at more of the other needs of the residents.
So I guess let's dive into the variable per diem. What is it, and can you tease it out a little bit?
The variable per diem, or VPD, as sometimes referred to, it gives a higher reimbursement. So for the first 3 days that the resident is in the facility, and it gives the higher percentage on the non-therapy ancillary component of the whole PDPM score. So there's five components to the PDPM score. The non-therapy ancillaries is the one, those are like the medications, things like that. It takes a little more of the nursing staff time and effort those first 3 days to get the resident in the facility and settled. So they get paid, it's actually 3 times more for that particular piece of the rate than on the 4th day. It'll go back to just the normal rate for that piece. The other part of the variable per diem, the physical therapy components and the occupational therapy components, on day 21 of the whole variable per diem day count, the therapies will start to decrease by 2%. Their pieces of the rate will start to decrease by 2%. And that will continue to decrease every 7 days by 2% until the resident either exhausts their days or they leave the facility. So with an interrupted stay, the VPD does not start over. So if they're out of the facility for 2 days and come back in, they don't get that 3 times higher rate the first 3 days. It just starts up from the day that they left. So if they left on day 20, they were gone 3 days or 2 days, I guess. And then when they come back in, the count itself starts on day 21 because it left off at 20. It now starts up again on the day 21 schedule. And if it is not an interrupted stay, then when the resident comes back in, that whole day count starts over again. So the first 3 days they're in, they get the higher rate for the non-therapy ancillaries. So
I love how you break it down, and even someone who works in marketing is able to understand this, but there has to be some confusion. I'm guessing when customers and facilities are going through the CMS regulatory updates, not all of this is so straightforward. Where would you say that facilities are getting confused or need the most amount of help or should pay the most amount of attention to make sure they're getting their reimbursements at the best, the fullest potential?
Right. Probably the most confusing part is that whole 3-day thing. Because prior to PDPM and this interrupted stay, when we had RUGs, if the resident left the facility for more than 24 hours, it was a whole new stay when they came back in. They had to do all the assessments again, and it kind of all started over. So that's a little bit of the confusing part, because now we have this 3-day piece, and so facilities just need to remember that if it's 3 days, they don't have to redo the Medicare assessment. and their payments will not start over at the higher rate for those few days. So.
And I think we might have briefly touched upon this at the beginning, but you said that we should talk about the assessment schedule. Can you kind of spell that out, and what is it under the PDPM?
Yeah, with RUGs, there was a number of assessments. There was a 5-day, a 14-day, a 30-day, 60-day. There were all these assessments that had to be done on a certain schedule. With PDPM, they've made that a lot easier on the facilities because there's just 2 that are required. An admission assessment needs to be done when the resident first comes in under PDPM, and then a discharge assessment when they actually leave or go to a lower level of care within the facility. They have to do a discharge assessment. There's another type of assessment in PDPM. It's called the interim payment assessment. I always call it an IPA. So it can be done if the resident's condition changes while they're in the facility. And so they can do this additional assessment to, reevaluate and maybe get a higher score, which means more reimbursement for the facilities.
What would they define as a change in condition? Can you think of an example?
Well, if the resident's in the facility because they have a hip replaced and maybe now they've contracted, pneumonia or something like that. So the care has to really change. So they need to reassess the resident to see what's the most important.
Understand.
And the interrupted stay, like I said, if it is an interrupted stay, you do not need to do another admission assessment. So it gives a little break to the MDS coordinators that they don't have to redo one every time some resident comes back in from, the hospital for a day, or so it saves them that time.
Great. This is a good overview. Is there anything that I didn't ask, or any extra points that you would like to include that you think that would be helpful for facilities?
Yes, one of the things, the billing piece of it, the important piece of the interrupted stay is that for the billing would cover the whole period, most facilities will bill on a monthly basis. So if you have a resident who left for 2 days in the middle of the month, that Medicare bill would cover the entire month, but it would show that 2 days were not covered. It would just make that, put those codes on there, and that says that the 2 days are not covered.
Very, very clear. I'm far from being a PDPM connoisseur, but now I know why the insiders inside Experience Care call you that, Sue. Thanks. This is detailed, helpful, actionable, full of easy to understand answers. Thank you for your time. Thank you for your passion, and thanks for your hard work. Thanks, Sue. Talk to you soon.